So with that, we'll move on to our next speaker. So Dr. Mark Bayley from the Toronto Concussion Study. He's going to talk about injury and recovery characteristics and prognostic indicators in a naturalistic cohort of adults with acute concussion. And for those of you who don't know Mark, he's a clinician scientist at the C.E.T Research Institute at UHN, Toronto Rehab, and a professor of medicine at U of T in physical medicine and rehab. And he's a leader in healthcare here in Ontario. Mark, please go ahead.
Thanks for that introduction. I want to thank also the Canadian Concussion Centre for inviting us to speak. I'm going to see if I can share my screen. So give me 2 seconds to make sure it works. And I'm going to see if I go into presenter mode, if we are good. Maybe Robin, you can just tell me if it's good. Okay. Oh, yep, I went to the beginning of this. Sorry. I'm going to just go to the beginning again. That's a good idea. Okay, thanks very much for the introduction. Very grateful to all of my colleagues who've been part of this, and you've heard from Dr. Rutan earlier, as well as Laura Langer and a few of us. So basically, I don't have anything to disclose related specifically to this, and I've received some speaking fees for nonprofit. So basically over the next 12 to 15 minutes, we're going to do two things: try and characterize the recovery of general population of concussion with previous, and comparing it specifically with the previously reported athlete populations. And we also felt that fatigue was an interesting symptom that we haven't talked a lot about, so that we thought that that might be an interesting thing to look at. As you've heard probably most of the day, we have 150,000 concussions in Ontario every year, and most people do recover, but there's continues to be no gold standard and no tests that really measure. So and there is a preponderance, as Dr. Tatter said in his previous research, of work on the sports population, but not the general population and the motor vehicle, as he highlighted. So the idea, and I have to acknowledge this is the brainchild, I guess, of Dr. Paul Comper, who wasn't able to speak today, who thought, well, what if we followed people in the general population in a systematic way? And so the idea was that we would have a rapid access clinic, and we would initially collect dozens of variables to better understand who and who doesn't get better. And then it will allow us to tailor treatment and also do innovative assessment and education. So as you may recall from Dr. Rutan, Leslie Rutan, we get referrals from emergency rooms across Toronto, about 6 of them. They're usually seen within a mean of 5 days, and all patients are offered the opportunity to participate in research, and we follow them systematically and clinically for 8 weeks, and then have a 16-week virtual follow-up for the research outcomes. This is the inclusion criteria. It's adults 17 to 85. The diagnostic criteria is that they have to be diagnosed by a doctor in an emergency room. Their Glasgow Coma Scale has to be 13 to 15. And we do not include people with positive imaging findings. And we also exclude people who are they are eligible for compensation, so that we would try and get in air quotes, pure cohort. And we then collect a lot of things. We collect their complaints, we follow the NINS, common data elements. We have objective measures of cognition and balance and psychological symptoms, as you heard from Leslie. And we have a multifaceted recovery criteria that includes a physician assessment. So this is over the last 4 years, we've had over 2,000 referrals. And not everybody agrees to come to the clinic. We have 838 who came to the clinic, and 500 of those consented to participate in the research. That's something to remember in the limitations of this study. And then you can see just a quick breakdown of the variety of different emergency rooms. Most of them are coming from Toronto Western and Toronto General. So what happens is, as we follow them, about 500 people are with us at week 1, and we have some people still being followed, but just to make it clear, we have about a 39% retention rate by 16 weeks, so about 40% still with us. So what's the characteristics of this population relative to the others? Well, as you've probably heard from Leslie, the average age is around 34, 33. It's 60% female. We have a slightly more educated population who have a bachelor's degree with a median income of 40 to 60,000. And this is the breakdown of anxiety, depression, and migraine. And I'm going to talk more about that in a couple of seconds. And then most people were employed. And so this is the mechanism of injury. We still have some people in the general population who are participating in exercise at the time of their concussion. And we also see a fair number of people who have a fall. And then, of course, hitting a head on objects, as well as bicycle and pedestrian. And in view of our conversation this morning about intimate partner violence, we do have about 8% of our population, which, as we heard this morning, probably underrepresents that group. So this is the trend to recovery over time. 46% are recovered by week 1, and by week 12, about 13%. So, and that this is the what we did was we mapped out, as many of you know, the SCAT score, or this symptom, the Sport Concussion Assessment Tool has a symptom inventory, and some of those symptom inventories, different domains have different scores. So what we did is we kind of normalized the scores by looking at the percent of the maximum symptom score on each of these domains, and you can see that the slowest to recover probably appears, or the sluggish is the somatic symptoms, whereas it seems like the emotional symptoms are lower, but they persist out to 16 weeks. And you can see that sleep is also in there. So then what does our group look compared to that sports population? So only 18% of our cohort was recovered by week 3. And 26% of the cohort was unrecovered by week 8, which is less than some of the numbers you see in the sports literature. And you can see that most of the recovery is with more than half of the folks recovering between week 4 and week 8. And as I mentioned, as you've heard before, you can see that women have more severe symptoms. This is very statistically significant, and they also have more symptoms on the SCAT. So now let's compare recovery. You can see that males appear to recover faster than females, and this has been shown as I think you've heard already from Dr. Tatter. And you can see that in our cohort, about 32% are not recovered at week 8. And similar to these previously published athletic concussion cohorts, females experience more symptoms acutely and are more likely to have prolonged recovery. So, and this is also work that's been reported by the Canadian Concussion Group as well, which is that the higher your score at onset, the more likely you're going to not be recovered at week 8. And you can see that those who were not recovered at week 8 had a statistically higher SCAT score at week 1. So this is very similar to some of the previously published athletic cohorts. And we also looked at some of the pre-injury diagnosis on recovery, and you can see that there was pre-injury depression and anxiety are factors, as well as the history of migraine or no migraine. We saw that statistically, people who have a history of migraine are going to have more symptoms acutely than those who don't. And similarly, as you heard from Leslie, those with pre-injury depression and anxiety have more symptoms acutely. So what was interesting, won't dwell on it because you heard it from Dr. Rutan. Again, the impact of pre-migraine does seem to be significantly reduce the reduce the chance of recovery by week 8. However, as you heard earlier, we did not find in our cohort that mood and anxiety were associated with slow recovery. So let's just, the quick takeaways from this comparison that we've been doing between the published athlete cohorts and our general population. Females are more likely to experience prolonged recovery, and that's the same in our population. A higher symptom burden acutely is likely to prolong recovery, and we also see this in this general population. We did not see that a past history of depression and anxiety was associated with a slower recovery. However, we did find that a past history of migraine headaches was more likely to have prolonged recovery. And our recovery on average takes 1 to 3 months, whereas in some of the concussion literature you see for athletes, it's of an order of 1 to 3 weeks. So just to quickly touch on the impact of fatigue in this mix, it's a very, very common symptom post-concussion, and we knew that it was frequently complained of by many people, and it does overlap with mood and sleep, but in itself, it's not as extensively. So what we did was, in addition to the other things you heard us talk about, we did a standardized Barrow Neurological Institute fatigue scale, and we did that similar to us, and we looked at whether the person's symptom severity and we of course looked at their symptom severity, and you can see the kind of typical questions on the Barrow. How difficult is it for me to maintain my energy, participate in activities because of fatigue, stay awake during the day, et cetera, et cetera. And so you can see similar, this is a slightly different cohort for which we have the data. It's very similar to our other demographics. And you can see that when you look at the Barrow neurological scores across, you can see that fatigue remains high for the first 6 weeks and then seems to be slightly improved by week 8. And it did seem that women experience more fatigue than men, and this has been reported in other, and particularly those with pre-injury depression experience more fatigue acutely, and this was consistent at the week 2 point as well. So what we found when we looked at the impact of fatigue on the concussion symptoms was we found that this fatigue scale was strongly correlated with SCAT scores, which means that we have to think about fatigue as a driver of symptoms. And we also noted that if you have a headache, it seems to be highly correlated. And again, these are correlations with fatigue as well. And we found that this fatigue scale actually accounted for as much as 1/4 of the variance in the SCAT total score, perhaps something that we haven't, thought about as concussion clinicians. So as Dr. Rutan did this morning, we have to highlight that we can't infer causation because the type of analysis we did was a follow-up. We did not have an intervention. And we also, we measured recovery at 8 weeks, and maybe we should look at recovery at a year and see if these have more robust correlations. And obviously, we know that this cohort may have been influenced by referral processes and the characteristics of those who are willing to agree to participate in our research. So just the key takeaways before we wrap up. As we said, the similarities between the general and the athletic females more likely to experience prolonged recovery, and a higher acute symptom burden is an indicator of prolonged recovery. Pre-existing migraines are associated with slowed recovery, but not anxiety in our cohort. And our recovery timeline is 1 to 3 months. And we know that we found that fatigue is associated with worse severity of concussion symptoms and worse headache in the first 8 weeks post-concussion in women and females. And those with pre-injury depression appear to experience more fatigue. Now, as you probably or may be aware, we have some a number that the Toronto Concussion Study that we've been trying to follow people at the Hull-Ellis. And if you scan this scanner, it'll take you to our webpage where you can get access to some of the publications. And of course, I'd like to just wrap up by thanking all the team at the Hull-Ellis Clinic. And I hope I didn't go over. I went to tried to go as fast as I can. So thanks very much for having us give you this overview.
Thank you, Mark. You did not go over. We're already running a few minutes late. And I think you might be off the hook in terms of questions, but I'll ask you one really quick question about, you have such a rich data set, and it's great that you are digging into it and providing answers to questions already. Are you starting to look at long-term follow-up as yet?
Yeah, we're I think we're out to 16 weeks, and we haven't looked at that, but I think the point of maybe taking some of the folks who agreed to participate in our research and calling them back a year later, I think it's probably a worthwhile effort at this point in time, because we have such a rich data set. So totally agree that would be a rich opportunity for us. And the other thing that we're, as some folks may know, we're the team at UHN, at the Canadian Concussion, as well as at Hull-Ellis, we are part of a project called Connect, which is with the Ontario Brain Institute, and that will allow us to link some of this data to other databases. So we're very excited for that possibility to be able to follow people long term. So thanks for that question.
That's great, Mark. And there's a question in the chat. We're going to just move on to stay on time, but there is a question in the Q&A for you that I can see.
Sure.